We're on. Go ahead.
All right. Well, today we have the pleasure of having Avik Roy on the show. It's no exaggeration to say that Avik Roy is one of the most important conservative voices in healthcare policy today. His path to health policy guru is somewhat of a circuitous one. He was born to Indian immigrants in Rochester, Michigan, and as a result, bleeds Michigan blue. He is also a fan of the Detroit Red Wings, who may have won a few championships in their time, though I'm sure he will agree that they will never be as great as the Pittsburgh Penguins.
Oh, jeez.
Ovik went to a little-known school that goes by the acronym MIT. I don't know what that stands for, and went on to Yale for medical school. On graduating, he went on to work for an investment firm you may have heard of called Bain Capital, where he focused on biotech companies and discoveries in that space. Somewhere around then, he became bored with the media narrative on healthcare and specifically the Affordable Care Act, and began a blog called The Apothecary. This was then quickly picked up by the National Review as well as Forbes. He quickly became the go-to policy wonk for critiques of the Affordable Care Act, and then went on to become a healthcare advisor for political campaigns, specifically Mitt Romney's presidential campaign, Rick Perry's, as well as Marco Rubio's 2016 campaigns. He now heads because of the success of those campaigns, he now heads a think tank that he co-founded called FREOPP. FREOPP. This is the Foundation for Research on Equal Opportunity that focuses on policy proposals that are intended to expand economic opportunity for all, utilizing the power of the market. I guess the contention, Ovik, is that it's still possible to have bipartisan endeavors in this polarizing time. As an example, he's a strong advocate, and we're going to talk about this, for the conservative case for universal healthcare. So Ovik, take me back to why you started a blog in 2009. What was the problem with the narrative as you saw it then?
Well, it was kind of something I suppose looking back now, it's a common entrepreneurial story in that I wasn't reading anything that was useful to me, or that I agreed with, I guess is the right way to put it. I would say I was reading nothing that was useful to me. On the center left to left, you had people who I respect, like Ezra Klein and Jonathan Cohn, who were talking about how, quoting Jonathan Gruber mainly, that the Affordable Care Act was going to reduce premiums for people and reduce healthcare costs, which made no sense based on the design of the Affordable Care Act as I understood it. And then on the right, you had people who were really not engaging the debate about what was wrong with the healthcare system and how to improve it, rather simply saying that the ACA was big government, it was unconstitutional, it was an expansion of the welfare state, all of which, of course, if you're a conservative, you agree with and are concerned about. But for non-ideological readers, there was no real engagement of, is the Affordable Care Act going to make healthcare more affordable? Is it going to make healthcare better? And people like Ezra and Jonathan and the others on that side were making those arguments, just I felt empirically not ones that I shared. And so I thought there was a need for more writing from an empirical or data-driven standpoint about how I saw the ACA's design and economic consequence. And the reason I felt strongly about that is because I spent 12 years as a professional investor in healthcare companies. And so I had a fairly experiential view from that vantage point of how insurance companies and other participants in the healthcare industry would respond to the incentives that the ACA would change, that I felt that the optimists on the left were not taking into account. So I started writing about it, and it took on a life of its own. And as you noted, it was picked up by National Review, then Forbes. Next thing you know, I was the opinion editor at Forbes, and a think tank in New York called the Manhattan Institute offered me a job out of the blue. And I said, I kind of have a full-time job as an investor, so I'm not sure I can do this. And they're like, oh, that's okay. We'll pay you for stuff you do in your spare time. I'm like, so you're going to pay me for a blog I write in my pajamas in my spare time? That's all right. So then I became a senior fellow at the Manhattan Institute, and then Mitt's team called and checked in, and just kind of was like one thing after another. And now that's all I do. I took a leave of absence from Wall Street to work on the 2012 Romney campaign, and never found my way back to being an institutional investor, because the need for articulating a vision, let alone a policy agenda that's market-based, but that solves the real policy problems that the Affordable Care Act and other such initiatives are trying to solve, is still out there, and there's a real need for that, and it's fun. I'd say as it's obviously not as lucrative as investing in healthcare companies, but it's really rewarding to know that you're at least trying to make a difference. I like to think that no matter whether I succeed or fail in making a difference, it's been worth the effort.
So it's interesting because around the same time, 2009, when you started your blog, essentially in opposition to a lot of the narrative driven by Jonathan Gruber and Ezra Klein and other colleagues, I was sold on the Affordable Care Act. I was like, this is great. I have, I was a cardiology fellow at the time, and I think an early cardiology fellow at the time, and to me there was like all these patients on the list that didn't have insurance, and now they were going to be given some type of ability to have insurance, and somewhere along the way I started a little small business and a practice, and I didn't want to deal with. I wanted my employees to have healthcare insurance, and somebody was coming along to say, hey, go ahead and have your employees buy insurance on these new exchanges. And so it seemed to me, and I knew nothing about healthcare policy. I still know, just slightly more than nothing now. But it seemed to me at the time that this was awesome. But yet, Avik, you at the same time felt that this was not going to go well, and it didn't go well. And I since then have learned the error of my ways after, but I had to live through it.
Yeah.
To learn the error of my ways. What I'm curious, what were the tea leaves that you read that made you so confident that this wasn't going to go well?
Well, there were two aspects of the Affordable Care Act in particular that in my early blogging days I became known for, because at the time they were extremely controversial positions, but have since been vindicated, or at the very least cannot be dismissed the way they were at the time. The first was related to health outcomes in the Medicaid program, because for all the attention that the Affordable Care Act's impact on the individual market, the healthcare.gov, the private insurance exchanges, et cetera, as much attention as that part of the ACA got, because it was the most novel part relative to existing federal policy, it's important to remind everyone that of the when the bill was first scored by the Congressional Budget Office in 2010 or 2009, roughly half the coverage expansion was meant to go through Medicaid and half through the exchanges. And so I was a critic of the Medicaid expansion because there's an enormous amount of literature showing that Medicaid's health outcomes are no better than those for people who have no insurance at all. And that's obviously a very counterintuitive thing to say. Like, that can't be. We're spending $500 billion on this program. Surely it's having some impact, making some difference. And it does, I think, have a financial impact on the ability of people to pay their medical bills. But it is striking and consistent in the literature and in some of the writing. I once wrote a book called How Medicaid Fails the Poor, summarizing all this literature. It's pretty consistent, and once you really understand how Medicaid works, and in particular the fact that a lot of doctors don't take Medicaid, particularly primary care physicians, that you can see why the health outcomes wouldn't be as good. Because if you're getting diagnosed for breast cancer when it's stage 4 rather than stage 1 because you can't get a mammogram because no doctor will see you, then yes, of course your health outcomes are going to be worse than someone who gets treated and seen right away. So anyway, I had a whole body of work around that a lot of my friends on the left side of center didn't like and criticized a lot, and we got into lots of exchanges about that. And then there was this big study that came out in the New England Journal studying effectively a randomized trial of people who got Medicaid versus who didn't, which everyone pointed to as the gold standard before the results came out. And then once the results came out, oh, no, that study was clearly not designed to show a significant result. Blah, blah, blah. But anyway, long story short, that was one thing that sort of
so you're already showing, what I wish a lot of my colleagues in medicine who pick policy positions based on platitudes and what sounds nice and what your tribe is saying. And I was one of those guys. And I was like, yeah, of course, this is a great option. But when you start delving into the details of how exactly you're delivering coverage, like in 2009, I had no idea that the way that, the Affordable Care Act was going to work was going to rely so heavily on Medicaid expansion. For many fellows and many people in medicine who are not at all, who don't have a clue how much Medicaid pays you. I do, because I run a little practice, how much Medicaid pays you for a follow-up visit. That automatically, it starts to fall on deaf ears. You start to see why these policy programs have a very small chance of working, if any. But it goes to show how you need some type of, you need a detailed understanding of what these policies actually propose, as opposed to like what they want to do. So,
what's interesting about that particular piece of the story, in terms of my evolution, is that it really built on all the work I did in my hedge fund days. So when I was an investor in biotechnology companies, the entire line of work involved analyzing clinical trial data and basically figuring out whether the stock market was overhyping or underhyping clinical trial results. So what would basically happen typically is, let's say you've got some promising new drug for Alzheimer's disease. In phase 2, it's shown promising data. It's improving mental status, in a certain number of patients. But when you dig beneath the top line data, which is published in the New England Journal, everyone says, oh yeah, this is great. There's this promising new drug. The data's in the New England Journal. It's so great. It must be awesome. Stock goes flying. It has a $2 billion market cap. But when you actually dig below the surface of the study, you find out that the patients in the control arm versus the drug arm had very different baseline health status. The actual way in which mental status was measured in the patients was statistically noisy, and there's a lot of reason to believe that the trial is not going to be reproducible in a larger phase 3 study. That was basically the kind of thing I did as an investor. So when I started writing the stuff about Medicaid, you had a lot of people who really hadn't delved into the medical literature, who were economists but weren't facile in clinical trial analysis. They were saying, oh no, Avik, you're wrong. Obviously Medicaid's wonderful. And I was willing to take that controversial view, not really for ideological reasons, but because I was fairly confident in my analysis of the clinical trials. And also, I think temperamentally, as an investor, that's what you do all day. You try to find the areas in which your point of view is different from everyone else, because when you're looking at the stock market, that's where you make money. It's because you have a view about a particular stock that you think it's either overvalued or undervalued based on this kind of data-driven approach. So that was an example. And the other big example was looking at the impact that the Affordable Care Act would have on premiums in the individual market for health insurance. So people who buy health insurance themselves, who don't get it from their employer or the government, I had the conviction, based on, again, empirical data, that the premiums were going to go up a lot. And this wasn't merely based on economic theory, though certainly the economic theory backs us up, because if you require insurers to deliver a much more financially generous product, well, they're going to pass those costs on in the form of higher premiums. That seems obvious. But what started to happen in 2013 was insurers started to file with the state regulators and federal regulators. Here is what we are going to charge in 2014 for these new insurance products that were being required to sell. And so I started basically compiling and documenting those regulatory filings and saying, okay, for example, in California, the state of California put out a report saying, we are going to save money for consumers. Premiums are going to go down in California thanks to Obamacare. Well, they did this apples versus orange comparison where they compared employer-based premiums in the old market to what Obamacare-based premiums would be. And employer-based premiums are more expensive than individual-based premiums because the individual market's regulated, or at least pre-Obamacare was regulated in a completely different way, the Affordable Care Act. So if you actually do an apples-to-apples comparison where you say, what could you buy what could you buy insurance for in California before Obamacare versus what you could do after Obamacare, the premiums were basically double. And so in 2013, I led a group that basically scraped premium data for every zip code in America, knowing that this data would basically not be available starting in 2014, so that we had it. so that once the 2014 filings were all complete, we could actually say, okay, in every zip code in the country, how are premiums for different types of people, old, young, male, women, et cetera, in 2014 versus 2013. And we published the data. And again, you had people like Paul Krugman saying, Avik Roy's a liar. This is all a fraud. He's just this right-wing guy. And I'm like, dude, I mean, like, I'm not guessing here. This is actual regulatory filings by the insurance companies. But, it had to go through that phase where people, the Kubler-Ross 5 stages of grief, where people said, oh, no, this is totally not happening. And then, of course, now they've accepted it and changed the subject, I suppose. But those two debates, the debates about Medicaid health outcomes and ACA premiums, were kind of the things that I feel like, because they attracted the attention of high-profile guys on the other side, seemed to elevate my profile. At least that's
and they've of course apologized to you and said, yeah, you were right, we were wrong. Paul Krugman, is he writing a New York Times op-ed on this anytime soon, I think? Or?
Well, I don't know if I've got any mea culpas, but I will say that Paul Krugman did invite me once to speak at a forum that he organized at the City College of New York, or it's the City University of New York. I always get them confused. And Ezra and I have been friends since the beginning. I think, Ezra and I actually, even though we disagree on a lot of stuff, I think we actually share a lot of similar ideals in a sense. Like I think, the Swiss system, which is one that I talk about a lot.
Yeah.
That's a system that Ezra also, I think, shares a certain amount of admiration of. And, obviously, there are certain things we might disagree with, but a guy like Ezra and I, we'll often joke that, if you put us in a room together, there's at least the theoretical possibility that we could hash out some sort of deal that he and I would at least find that we could live with. Maybe not everyone else could, and Paul, he's obviously a polemicist. His views on healthcare, I think he gets from other people. I don't know if he researches the data himself and has self-developed views on this stuff. So I kind of take that for what it is, I suppose you could say. I remember the first time he wrote about me in the New York Times, I was kind of grinning from ear to ear. It's like, I really made it. Paul Krugman has written an op-ed saying I'm a terrible guy. So I will say he did write something nice about me on a completely different subject later on when I was commenting on some of the trends I saw in 2016 politics that he.
So this is a good segue then in terms of your agreements with your possible agreements with Ezra Klein. You're a champion for the conservative case for universal health care. So let's start with a really simple question. Do you make the case for universal health care because you believe health care is a right?
Well, I do believe health care is a right, but I define rights the way the classical liberals define rights. So I actually wrote a piece for Forbes. Actually, it was a speech I gave to the Yale Political Union. I adapted as an article for Forbes called "Yes, Healthcare is a Right. It's an individual right." And what I meant by that was that the rights that classical liberals tend to value, the rights to freely choose to buy the things you want to buy and not buy the things you don't want to buy, is essential to how a healthcare system should work. And that the idea that if you're going to say that healthcare is right the way the left does, which is that people should be taxed, i.e. their property should be taken away from them in order to provide healthcare to everyone as a right, and you're going to define it as a right, well, that's a great bumper sticker. But then you have to define what healthcare is. Is Viagra a right? Is the right to $1 million biotech treatment that extends your life by 2 weeks on average? Do you have a right to that? Do you have a right to ineffective treatments? Do you have a right to treatments that really aren't about survival or health per se, but more kind of luxury goods in terms of health enhancement? Do you have a right to Botox? When you get into the brass tacks of defining healthcare, it becomes a lot more complicated to say healthcare is a right the way the progressives define it. And so I think there's a middle ground here, which is to say that the arch libertarians who say that, well, no, I should get to keep all my stuff and you can't take it away from me, and the kid who gets born with Down syndrome, tough luck, that's a kind of an absolutist libertarian position that has a lot of flaws to it. And then the position that, well, all healthcare is a right and everything should be free to everyone, that's obviously not realistic either. So what's the balance? What's the right balance between making sure that people have the maximum amount of choice in the kind of healthcare they obtain and can provide, and at the same time that we have that basic safety net and that basic sense of, if you've encountered some sort of misfortune in your life, we as a community are going to come together and make sure that we take care of you. And Friedrich Hayek, in the Constitution of Liberty and elsewhere, argued for this. He argued for universal coverage to protect against what he called the hazards of life. Ronald Reagan wrote about the fact and has spoken about the fact that no American should go without health care because of an inability to pay. And so if Ronald Reagan and Friedrich Hayek can support universal coverage, surely mainstream conservatives can as well. And that's a more moral and philosophical argument. There's also an empirical argument here, which I think is actually more powerful than the moral arguments, because we're all going to have our moral and philosophical precepts that we may never agree on. But the empirical arguments are really compelling. And let's look at Switzerland as an example of this. So the conceit that a lot of people have had in America is that, well, America is this free market healthcare system, and we should be more like Europe if you're on the left, or we should be less like Europe if you're on the right. Well, the irony of all that is that there are countries in Europe, Switzerland is the main example, that are more market-oriented than the United States. So in Switzerland, there aren't any public options. There are no government insurers. There's no Medicare. There's no Medicaid. There's no VA. Everyone in Switzerland buys coverage from a private insurance company, and yet they have universal coverage. And they spend half of what we spend on healthcare, both from a total standpoint and also from a public spending standpoint. So their system is much more fiscally sustainable than ours. And yet it covers everyone. And there's the same access to technology, the latest drugs, the latest medical devices, full choice of doctors. So all the caricatures on the right say, well, we can't have universal coverage because then we'll have 14-month queues for knee replacements like they do in Canada. Well, Canada is not the only model out there. And that's, again, a misconception on both the left and the right. So a big part of why I talk about countries like Switzerland and Singapore and others, and again, this is the power of the empirical argument, is that our healthcare system in America is so messed up that both the left and the right can win at the same time. You can have a system in which everyone has that basic financial security that comes from having health insurance, knowing that you're not going to go bankrupt because of medical bills, which I think is a laudable public policy goal. And at the same time, you can have a system in which there's more choice and more fiscal sustainability and more flexibility and less government intrusiveness than the system we have in America.
So we're fortunate to have an arch libertarian on this podcast as well. Michelle, tell me.
Only one?
Tell me why healthcare shouldn't have a special place. Even Hayek is giving healthcare a special place in terms of saying, "Hey, look, we have to kind of provide some type of a safety net."
Right.
You know, so
there's a special place in hell for the Hayekians.
I know there are lots of there are lots of arch libertarians who think Hayek is a communist. So
right, exactly. No, but before we get there, actually, I'd like to flesh out a little bit what your vision is. But one thing I want to say is that the Swiss, you know, on this podcast we had a Swiss physician a few months ago tell us about the Swiss healthcare system. He's not all that optimistic about his own healthcare system from the way he views it, and he's not particularly libertarian. There's been since, you know, it's in a way it has some resemblance to Obamacare, the Swiss healthcare system, in that there's a mandate for everybody to purchase health insurance, and there's a subsidy for people who are poor to buy health insurance on private markets. Apparently there's been a stalemate for several years now about how the doctors get paid and the hospitals get paid. So he hasn't had a raise in several years. there's been an increase in medical cost inflation from, over time, which preceded was there even before their system was put in place. But they have the same problem that everybody has. It's less acute than what we have here, but it's still acute. That there's this, you can call it moral hazard or whatever it is, but when people have health insurance, they end up using more.
Sure.
And there is, and so healthcare expenditures in Switzerland are above the general inflation, the rate of general inflation, and so forth. And it doesn't seem to be, it's more sustainable now but in the long run, unless they do something, and that something will be a deviation from what they have now. So unless they do something, it doesn't seem that it's working all that well.
So let me stop you there, because if you make too many points, I won't remember them all. Okay. So broadly speaking, if you talk to anyone in any healthcare system, there's always a criticism of every healthcare system, right? There's no healthcare system that's not going to have its critics. It's kind of like, they're always, if you have a favorite sports team, there's always something to criticize about it. For every player, there's always something to criticize about his game. Same thing is true in healthcare systems. There's always something to complain about. Healthcare inflation is not, there's no country that has figured out how to solve healthcare inflation. Healthcare inflation, regardless of what the baseline is, what the absolute spending level is, healthcare inflation is roughly the same in every country. In fact, U.S. healthcare inflation is below the OECD average if you look at the last 10 years. So yes, healthcare inflation is there in Switzerland, it's there in the UK, it's there in Canada. There's no system that solved the problem of healthcare inflation. So yes, people who are experts in local systems have their concerns about that everywhere. But where you have to look at it from an American perspective is, would the Swiss system be an improvement on the American system? And the answer is unequivocally yes. And let me be clear, I don't support the individual mandate. And in all of my writing about Switzerland, I've made very clear that that's one of the aspects of the Swiss system I would not want to import. In fact, you don't need the individual mandate to solve the alleged problems of gaming the system when you cover pre-existing conditions and all that. And that's a conversation I won't bore you with unless you really want me to. But what's really useful about the Swiss system is it's a system in which there's competitive markets in every region of the country with private insurers, and B, there's a sliding scale of subsidies that phases down over time as you go up the income scale. So there's no cliff. It's not like Medicaid, where if your income is above a certain threshold, you lose the benefit, which has a severe disincentive for people to work those extra hours or take that raise or take that nicer job because they might lose their healthcare benefits. In the Swiss system, there's this gradual phase down, which Obamacare did borrow from, and because Obamacare has a similar phase down of the subsidies in the healthcare.gov health insurance exchange markets. So that I think is good. And I think that's something about the ACA, which I actually have been vocal in defending, actually. Back in 2017, when Paul Ryan was advocating for a different system, he and I had plenty of both private and public arguments about that, about having a cliff-type system versus a gradual phase down. So those are the things that Switzerland does well. And yes, again, like, does everyone want to make more money? Sure. Are people getting older and sicker and spending more money? Yes. Are drugs becoming more expensive? Yes. But again, if you look at the Swiss system, in terms of public spending on healthcare, the Swiss system spends 45% of what the United States spends in terms of public expenditures on healthcare. In terms of private expenditures, we spend about 19% of GDP. They spend about 12% of GDP. And remember, the top federal tax rate, income tax rate in Switzerland, do you know what it is off the top of your head, Michelle?
No, I don't actually.
It's 11%.
Right.
So, like, I think if you're a libertarian, would you want a top rate of 36% or 11%? If you're going to complain about that, then I think your priorities are misplaced.
No, but I'll answer briefly about the libertarian. So there's a libertarian ideal where actually that was the only time where the healthcare inflation was not it was actually below the rate of general inflation, because and that's 100 years ago in the U.S., United States, pre-Flexner, and then you had institutions like the Mayo Clinic that could actually offer charity care for 30% of its patients.
Sure.
right? 30%. So, but I understand. I understand that there's no way we're going to get.
We're not going to have a
realistically, we're not
libertarian
gonna- it's
system.
gonna
So
happen.
that's
Correct,
part
right.
that's part of the argument here, right? Which is what's the realistic landing point that's democratically stable? This is another thing about Switzerland that doesn't get commented on a lot, which is so the green and socialist and new democratic type parties or social democratic type parties in Switzerland have agitated for single payer, replacing the Swiss system with single payer. And Switzerland has an extremely developed referendum system, much more advanced than anything we do here.
Right.
And twice, both in the late 1990s and more recently, Switzerland has had referendums to replace their system with a single payer system, and those referendums went down by a 3-to-1 margin, plus or minus.
Right.
So that tells you that for all the alleged critiques and dissatisfactions that any pundit could come up with of the Swiss system, the popular support for it is very high. And that's one thing that an arch-libertarian system would not have.
No.
An arch-libertarian system in which people went bankrupt due to medical bills would not be democratically sustainable.
No, fair enough, and I'm really willing to hear the case that you're making, but let me ask you another question, because I really don't know. I didn't do my homework the way Anish did. What would happen to Medicare under your vision? Would you keep Medicare as is, or would Medicare be folded into a similar type of program where
well, in Switzerland, there is no Medicare per se, in the sense there is not a different system for people over the age of 65. Everyone from birth to death is in the same system, in which, based on your income, you get a subsidy for your health insurance premium. So if you're poor, that premium may be completely covered. If you're rich, it's not covered. But otherwise, everyone has the same type of insurance market they're participating in. So I look at Switzerland much in the way that people like Bernie Sanders look at single payer, the UK or Canada systems, as a goalpost. I look at Switzerland as the goalpost in terms of a system in which ideally we don't have 2-tier or 3-tier or 4-tier systems where wherever people need financial assistance to buy health insurance, we're providing it to them. And people who don't need financial assistance to buy health insurance, we're not providing it to them. So to give an example, in Medicare, you and I, Michelle and Anish, we all pay income taxes or payroll taxes so that Warren Buffett can get government subsidized health care. That strikes me as completely idiotic. Now, there are people on the left for ideological reasons say, well, that's a great system because it's wonderful that rich people have to buy socialized or single payer health care the way poor people do. But it's absolutely insane from my standpoint that middle class people and lower income people are working their butts off paying taxes so that Mitt Romney and Warren Buffett and Hillary Clinton can get government subsidized health insurance.
Absolutely. It's funny. I made that point, that exact same point to we had Adam Gaffney. I don't know if you know him.
Oh, yeah, sure.
Adam Gaffney was on our show, and I made that point to him. So, but just to understand correctly, essentially, your vision would be essentially to fold Medicare into there wouldn't be a distinction. There'd be one. One system
to be clear, that's the goalpost. I think a goalpost is a system in which everyone has access to affordable health insurance, regardless of income, age, or health status. Or gender. Now, and in one system. I think having it integrated into one system where everyone is buying private insurance is the ideal. Now, I don't think that it is realistic or viable or wise to just say, we're just going to scrap the system we have to try to establish something different. I think what you have to do instead is create a policy environment in which it's financially and economically advantageous for people to choose that kind of a system. So, for example, to take Medicare. Right now, Medicare is 4 parts. There's Medicare A, Medicare B, Medicare C, and Medicare D. Medicare A and B are the single-payer 1965 vintage versions of Medicare. Medicare Part C is a private insurance administered version of Medicare, and Medicare Part D is, of course, for prescription drugs. A, B, and C are for hospital care and for physician-administered care. And why does that matter? Because actually, this is remarkable. If you break it down, enrollment, absolute enrollment in single payer Medicare A and B is declining. It's declined over the last couple of years, whereas Medicare Advantage enrollment is skyrocketing. Why is that? It's because Medicare Advantage plans are less expensive and have better health outcomes than traditional single-payer Medicare plans do. So a lot of what I support when it comes to Medicare is to make those advantages more salient. That is to say, right now, the way Medicare works, for example, is that when you turn 65, you're enrolled by default in single-payer Medicare, even though Medicare Advantage is less expensive for you in terms of the premiums and has better health outcomes. So why is it that we don't have as a default option enrolling in Medicare Advantage plans rather than single-payer Medicare? Now, obviously, again, the ideologues on the left for whom the private sector is anathema, they're not going to like that. But if you actually say, what's in the economic interests of seniors, it's very much in their interest. So if you do something like that and you actually means test Medicare such that the people who are the Warren Buffetts and the Mitt Romneys are no longer eligible for the program, where the program is really zeroed in on the people who need financial assistance to afford health care, you do those things in a gradual way that aligns the way Medicare supports health insurance with the way the employer-based market and the Affordable Care Act do. You can basically take all of these programs in a glide path that over a 30-year period aligns them all in a way in which 30 years from now, the way we think about the way you buy health insurance when you're young versus old, rich versus poor, employed versus freelancer are not that different. Does that make sense?
It does, Avik, but a couple points. One is that, Switzerland before 1994, Switzerland is a direct democracy. So they vote on, my understanding is they vote on policy proposals. In 1994, they voted to address a problem that they had with health insurance at the time. At the time, in 1994, 97% of the country was covered with health insurance. But the problem was that insurance premiums were rising. And, in an effort to try to figure out how to both get universal healthcare, meaning go from 97% that was covered to 100%, as well as to deal with the rising spiraling cost of healthcare costs, of insurance premiums, they had to vote for a new system. And this is always what ends up happening is the new system involves a national fee schedule, right? So again, you get into this, and there's all sorts of issues that then get opened up when you do that. So the consequence of the law is that every citizen gets health insurance. Every licensed doctor can bill this third party. The comprehensive insurance benefit, is determined by some small panel of federal authorities and includes complementary care such as homeopathy, acupuncture. So, I remember Mark Ferdulis, who's the Swiss physician we had on, was talking about the fact that I forget from what country, acupuncturists sort of streaming into Switzerland so they could bill third parties. So I get the fact that Switzerland is 11%.
Anish, that happens here. So
yeah. No.
Has a mandate for acupuncture that the acupuncture lobby heavily lobbied for, and there are plenty of states where that's where there are insurance mandates that. Go ahead.
Right. I get it. I get that. I get the trade-off, and it's an important point that you're making about the fact that look, they have the system, but their economy is unfettered with a tax rate of whatever we pay 30-40% and whatnot. But the basic issue I'm finding with the conservative stance on healthcare, which espoused by folks like you, is that it's like the free markets work everywhere, but healthcare is seen as a problem where we just need the costs to be controlled so we can do our thing in terms of the regular economy. And in terms of controlling costs, it always comes down to some type of fee schedule, some type of rationing that involves a third party. So Medicare Advantage, and again, I have a slight disagreement with you in terms of Medicare Advantage, in terms of why it does as well as it looks like it does, because it's clear to me that Medicare Advantage selects out a group of patients, a group of folks from Medicare. You can't, dialysis patients are not Medicare Advantage. There's some hospice provision in term as well, but it selects out a group of patients that are definitely lower risk than the traditional Medicare population. I tell my patients all the time, I'm a cardiologist, so it's a selected sample because I see patients that are a little sicker than average. But I tell my sicker patients all the time that, look, do not, when open enrollment comes around again, do not choose Medicare Advantage because it is too hard for me to navigate. The only one place in the city will do iron infusions for a guy who needs chronic stuff, and he lives far away, and it's a mess to try to coordinate. And so Medicare Advantage, the reason Medicare has kind of moved and loves Medicare Advantage is because Medicare can't say no. And that's a problem that Medicare can't say no, so that you have folks that are doing stress tests every year on 90-year-olds, which is horrendous and terrible. And Medicare Advantage doesn't, has a backstop. It has some panel that's saying, no, you can't do this and whatnot. And they have narrow networks in terms of what you can do, where you can use. They have higher copays for specialists, et cetera. So it always seems to come down to, whether you look at the Swiss system or you look at Medicare Advantage, that these systems involve some type of cost controls. And the problem with cost controls is getting the price right. Like, who do we trust to get the price right? Would you trust some small governmental body to get the price right of of shoes? You would not. So why would you assume, or why can we assume that some small panel of folks somewhere, no doubt advised by Paul Krugman and Jonathan Gruber and who all, are going to get the price right for healthcare, which is incredibly important. I mean, it's way more important to getting the price of healthcare right than it is to get the price of shoes right.
Well, there's a lot to say about this topic. I mean, we could spend an hour talking solely about the role of prices in healthcare. First of all, let me just say that, once again, like, I'm not endorsing, I don't endorse the way the Swiss do their fee schedule. I mean, for me, what's core about the Swiss model is the fact that it's a universal system of private insurance in which the subsidy scale phases out as you arrive in the middle class. And therefore, it's a true safety net program. It's not a system in which wealthy people are subsidized, and where the form of the subsidy is premium assistance for you to buy the insurance that you want to buy. That, to me, is the skeleton, the framework that about Switzerland I find really appealing, and I have my share of quibbles with the other aspects of the Swiss system. So that's just to be clear about why I like Switzerland, why I talk about it. In terms of your broader conceptual question, which is what's the role of the government or regulators in pricing? I advocate, as a market-based guy, for the lightest possible touch. But the lightest possible touch, in my view, does not mean, as our House Libertarian Michelle would argue, it doesn't mean zero touch. And the reason why it doesn't mean zero touch is because of the existence of monopolies. So there are monopolies all over the healthcare system. This is something, where just to take a detour here on your criticism of Medicare Advantage. Yes, Medicare Advantage does have the ability to have narrower networks in terms of they don't have to include everyone in their networks, a Medicare Advantage plan. But they are subject to network adequacy requirements. They can't just, exclude all people who do, say, a particular type of specialty. They have to have some people in their network that do that. And that creates the countervailing problem, which is, let's say you're the only neurosurgeon in a rural area and an elderly person has a stroke. Well, Medicare Advantage has to have that neurosurgeon in their network, because if you have a stroke and you live there and he's the only game in town, tough luck. So the monopoly problem is far more important in terms of costs and prices than are things like fee schedules. And then the other piece of it, where you said, well, don't go on Medicare Advantage if you're sick. All of the literature that is taken seriously in academia addresses this. It's all risk stratified. It all tries to look at patient populations that are comparable, and in those studies, Medicare Advantage does do better. And by the way, Medicare Advantage offers a broader range of benefits, not a more narrower range of benefits, but a broader range of benefits, which includes things like vision, dental, and supplemental benefits on the traditional healthcare side. So, again, I would just disagree. That's maybe a topic for another time. But the literature is so extensive on this now that even people on the center left don't disagree with it. So that tells you that the
Yeah.
consensus is pretty strong on this point. But more broadly, again, about your question about prices, I think that where possible, the price should be set by the market. And an example of this in healthcare is where drugs go off patent. So when Lipitor went off patent, a best-selling cholesterol-lowering drug, and the generics came in to compete with branded Lipitor, which was manufactured by Pfizer. Now we have a competitive market for that drug where the price has gone down by 80-90%, and there are 10 or 15 different manufacturers of atorvastatin, which is the generic version of Lipitor. And if you need to get your cholesterol lowered, you can go to a Walgreens or CVS and buy a drug that costs literally less to manufacture or sell than a bottle of Poland Spring. And that's wonderful. That's the market driving the price down. That's not the market saying, well, Lipitor reduces the incidence of major adverse cardiac events by X, and therefore we're going to pay X times 10,000 for it. No, the market is setting the price, and the market is setting the price as being dirt cheap. That's how markets work. Markets don't work by saying the health outcome is Y, so the price is Y times a factor. The market says this is the supply and this is the demand. And in the case of atorvastatin, the supply is massive and the demand is massive, but the supply is much larger, and therefore the price is cheap. That's how the market works well. Now, a flip side of that, sticking with drugs, is where you have a branded drug that is a monopoly because it has a patent and it's the only drug that treats a particular type of condition. This is particularly endemic for rare genetic disorders these days because most of the common diseases are treatable by generic drugs. In fact, 90% of all prescriptions in the US are for generic medications, which are dirt cheap. But in those monopoly situations, how do you set the price? You're arguing, Anish, that it's really unsavory if Jonathan Gruber and Paul Krugman are setting the price, and I think there'll be plenty of people who might not have confidence in John and Paul to set the price well. But at the same time, do we have confidence that the monopolist is setting the price in a way that's rational or fair or in the public interest? I think the track record of monopolists in the prescription drug space is almost unanimously negative in that regard. There's enormous amount of evidence of monopoly exploitation of pricing power, not just in prescription drugs, but let's stick with that for the moment. And so from my standpoint, there is a role for the government to, both in terms of antitrust and in terms of putting a ceiling on monopolist price exploitation. And again, this is where maybe the arch libertarian who actually has no problem philosophically with monopolies and someone like me where we might be different.
Right. I mean, I think we'd make the distinction between monopolies that are artificial because they arise by virtue of some other government intervention, some other regulation that allows those monopolies to form, which in healthcare is almost invariably the case, versus a natural monopoly where typically if you have a natural monopoly it's because a company is actually lowering prices so much and is so efficient that no other competitor can come. I think most of the monopolies that you're talking about are going to be monopolies that have arisen because a hospital chain can take advantage of certificate of need laws or things like that, things
sure.
That's
a big problem.
Right.
The artificial monopolies are a big problem, and in my writing on this topic, I have a detailed critique of all those artificial ways in which we monopoly power in the healthcare system. What we should do to reform that.
So, like I said, we could spend many hours talking about this. I can't let go one thing though. You have to be really careful about risk adjusting that's based on claims data. I'm telling you, Avik, there's something screwy here. As a guy, I mean, again, I'm.
Well, listen, if there are things
risk
adjustment, let's fix it. CMS has the authority, the regulatory authority to do that, and they do every year. They tweak the risk adjustment formula. If there continue to be things to adjust, let's adjust them.
It's all gaming the metrics because the payment to Medicare Advantage is based on the how high risk the patient population is. So there's a big push from these guys, from the Medicare Advantage guys, to call primary care doctors, call physicians to get them to code in a way that makes folks look risky. There's all sorts of data that looks at the moment you go from Medicare to Medicare Advantage, suddenly the same person is like looks much sicker. But anyway, a small point. But let's since we'll start to wrap up here. How has free up? What have you been doing with free up, and how are things going with free up in terms of you moving the needle on, especially in a time where are the conservatives in power? Are they out of power? Who's in power right now? Who's listening to what free up and folks like you have to say?
Well, to be clear, I mean, we're trying to occupy a space that's not really conservative or liberal per se,
Right.
or to put it a different way, we're trying to achieve progressive policy outcomes using means that are often identified with market-based proponents. And so that's conservative in some ways and progressive in some ways. And I alluded to earlier the concept that our healthcare system, or the observation that our healthcare system is so messed up that progressives and conservatives can win at the same time. As Switzerland and other countries show, you can have a system that costs less and spends less money and is less intrusive from a government standpoint, but also achieves universal coverage and achieves that level of financial and economic security that universal coverage brings to a country. So much in the same way. So why did we start Free Op in 2016? A big part of the reason why, it's not the only reason, but a big part of the reason why, is because we found that observation about healthcare was not just true of healthcare. It's true of a lot of areas where there were market-based ideas for reform that had a progressive policy outcome, that expanded social mobility, that expanded economic opportunity for those who least had it, whose significant impact and benefit was for Americans whose incomes or wealth were below the US median. And so we thought there was an opportunity to develop ideas along those lines across a broad range of policy sectors, like education, like housing, like transportation, like criminal justice, like immigration, where we felt that there's this trend, obviously, as we all know, towards polarization. And we're basically being the contrarians against that. We're saying, actually, there's a hunger in America and among policymakers for ideas that have common ground. And equal opportunity as a principle is one that 80 to 90% of Americans, if you look at public survey data, share. We may have different views about what equal opportunity means or how to achieve it, but we share the principle of it. And that's as good a ground as any to try to build on. And at the end of the day, if you want, you asked the question about, do you want Democrats or are Democrats or Republicans in power? Well, at any given time, Democrats and Republicans are both in power, particularly in the Senate, where to get anything meaningful passed, you need 60 votes. So if you need 60 votes to get anything meaningful passed, how are you going to do that with a partisan approach to policy R&D? You actually have to have an approach that really brings people together. And so our argument is, look, if you have a free market idea that expands social mobility, you're going to attract conservatives who like free market ideas, and you're going to attract Democrats who believe in social mobility. And that's what we found. We found that to be absolutely the case, not just in healthcare, but across the policy areas that we've been active in, that you get a fair hearing from both sides if you are genuine and serious about building up from that common principle. And that's a rule we have at Free Op, that every op-ed we publish, every white paper we develop, every scholar we hire has to center his arguments around whether or not a particular proposed reform or existing policy would make a difference for people whose incomes or wealth are below the U.S. median. And that way, you build a credibility, you build a brand that both Democrats and Republicans can give a fair hearing to. And having worked on 3 presidential campaigns, I know how much the policy shops in presidential campaigns really depend on credible work from think tanks to help provide them with the policy agendas that they campaign on. So it can be really, there's a leverage point there that we're trying to take advantage of as well.
So you're telling me that the Free Op is just as appealing to Beta O'Rourke as will be to whoever else may run in.
Well, I mean, obviously, I don't want to speak for any particular candidate, but I can tell you that that we do get a hearing from Democrats and Republicans. And yes, I mean, I'm a guy who's personally, I think of myself as a conservative, but obviously, I'm a particular type of conservative. I'm a conservative who's looking to achieve progressive policy goals, and And that's true of everyone at Free App, that we're all trying to achieve progressive policy goals, whatever term we would use to define our own political beliefs. And I can tell you that there are plenty of Democrats, and not just center-left Democrats. There are plenty of people who think of themselves as progressives, who like a lot of what we pitch. And again, it's not, we may not agree on every single issue, right? But take drug pricing, for example. There's a lot of common ground between what people on the progressive left talk about on drug pricing, or at least many of them do, say abuse of the patent system, for example, and what we talk about. There's plenty of overlap between what some people on the left talk about when it comes to hospital monopolies and the abusive practices of hospital monopolies and what we talk about. So, again, we may not agree on every issue, but if we agree on those issues and we can develop legislation around those issues, and by the way, there is legislation that's been introduced in Congress around some of these ideas, then we're getting somewhere.
It's hard to get a read on where the Trump administration is in terms of healthcare policy and what their larger goals are, other than providing the best healthcare known to man, apparently. Are there lines of communication that are open from the Trump administration to someone? Who are these people? Like, what's your feel?
I think that the Trump administration has put out a lot of stuff on healthcare that no one has paid attention to, because everyone's been chasing this Russian collusion story for the entire history of the Trump administration, which is increasingly being shown to have been a waste of time. And that that means that if the way you get your news is by watching cable news every day or reading the front page of your local or national paper, you're not aware of all the initiatives that have come out of the Trump administration in healthcare, because they're not being covered by the media, which is chasing the shiny objects of the Mueller investigation and things like that. But there's been quite a bit that they've put out. The blueprint that Health and Human Services Secretary Azar put out on drug pricing was based, I will say, if I'm able to, a lot on our work on drug pricing reform, and is quite substantive. And it was knocked at the time because it didn't involve price controls. Everyone's like, oh, this is a nothing burger because there are no price controls in here. And it's like, well, there's a lot of things you can do to reform the abuses that go on in the prescription drug system that don't involve price controls. And so that was an example of where your typical journalist who's looking at a bright shiny object does not have the policy chops to understand the significance and the impact of the things the administration is doing. And I think their strongest initiative has been in this area, in prescription drugs. They've also done some really interesting things in terms of reforming the way employer-based insurance works, and some minor reforms around the individual market. There's always more to do, and again, I think that in Congress there's been some interesting initiatives. There's a congressman in particular named Bruce Westerman from Arkansas who's put out a plan just a couple weeks ago called the Fair Care Act, which tackles hospital monopolies, it tackles prescription drug pricing, it tackles employer-based health insurance, it improves Medicare and Medicaid. Look, all the things. It's a pretty ambitious bill that amplifies and supplements a lot of the bipartisan conversations that we've been talking about. So there's a lot out there, and I think as we get into the 2020 presidential campaign, whoever it is that comes out of the Democratic side, whatever their ideas end up being, whether it's Medicare for all or something that builds more on the status quo, I think there's going to be that debate, right? The Democrats are definitely going to engage on healthcare and have a debate about how the healthcare system should change. And the Trump administration is going to have a story to tell about the things that they've done and the things that they want to do that I think a lot of people haven't been paying attention to.
Is this a pleasant surprise, Avik, in terms of how you thought things would go?
It was hard to really have expectations of how the Trump administration would go on healthcare from the way then candidate Trump campaigned, because his campaign and when it comes to healthcare policy, there was not a lot of depth there. There was a lot of kind of bullet point type.
There were 7 bullet points. What are you talking about?
Not a lot there. There was not a lot of there. So it was hard to know exactly how it would go, except for the fact that I will say that the one thing then candidate candidate Trump had campaigned on in the primaries and the general election was that his plan would cover everybody. Right. He was an outspoken advocate of universal coverage, which in a Republican primary was quite, he didn't do that because he thought that was going to win him the votes of the Wall Street Journal. he did that because that was clearly a conviction that he had. And I have to say, as someone who has been an advocate for universal coverage, I admired that about him for all the things that one can quibble about his style. I thought that was impressive that he took that stand from the very first Republican primary debate to the last. And so I was hopeful that his plan to replace Obamacare would reflect those principles. I don't think in the end it did, because of course he outsourced it to Congress, where that wasn't really how the congressional debate played out. But having said that, I think that he, particularly once he brought Azar in after Price resigned, I mean, Azar is super impressive. It's a guy who's just intellectually extremely smart. Because he was deputy HHS secretary before, he knows the system. Because he was president of Lilly USA in particular, he knows the games that the drug industry plays, and knows where all those loopholes are, and has been in a very subtle and targeted way attacking those loopholes. And he's got an incredible management skill. He's run large organizations very effectively, which is something that I think a lot of people don't always look at when they're hiring cabinet secretaries. And he's done that. So like in terms of running HHS as a large bureaucratic organization and steering it in a way that makes it effective, he's been extremely good at that. So I think Azar is going to, whenever he steps down, people are going to look at his legacy as an HHS secretary as a guy who really did a lot of things, and really he was more effective than any HHS secretary that I can remember. And so there's going to be a lot to talk about in terms of this administration. Now, does that mean there are things they haven't done that they should be doing, or things they've done that I disagree with? Of course, there are always things that you're going to quibble with, or things they could be doing differently. In particular, I would love to see the Trump administration take on the hospital monopoly problem more aggressively than they have to date. But part of why they haven't is because a lot of what needs to happen on hospital monopolies is something Congress has to act on. It's not something that the administration can do on its own. But there are things the administration can do on its own, particularly when it comes to the FTC and the DOJ and antitrust litigation. And I'd love to see them do more of that.
Wonderful, Avik. Thank you so much for coming on. Michelle, any last thoughts?
No, I would just want to say that I'm very appreciative of what Avik is doing, and certainly your arguments are persuasive in that what you propose would be an improvement from the current state, which is really terrible and headed for a cliff here. In particular, is the fact that you said that you're not in favor of mandates. Because from my standpoint, my little libertarian parasite, I don't have ambitions for reforming the entire system. I just want some opportunities for people, like me, and you probably have heard about the direct care movement.
Sure.
Which is really embryonic now and very small, but very dynamic and very, in my mind, very hopeful. It's not going to be a solution for 300 million Americans, but we want to have the breathing space to be able to continue to do what we're doing and sort of slowly increase. And therefore I feel the progressive agenda, the standard ones, are always a little bit threatening if they start mandating things that would put us out of business one way or another. And so to the extent that you allow that freedom to continue for anybody, including current Medicare age patients, to sort of maybe drop out or go on their own or have their own, private healthcare, and then be able to contract more freely with physicians or other little hospital systems. I think that would be a great benefit to the country. So.
Well, I think direct primary care could be a solution for 300 million Americans, in the sense that that's how everyone should get their primary care. It may not be the solution for orthopedics, say, but for primary care, the direct model, the retainer-based model, I think is something that has, if not universal applications, at least near universal applications.
Right. Although
But
I think
as
even for orthopedics, so long as it's outpatient.
Yeah,
I think
exactly.
The
For
direct
elective
care is
outpatient,
extremely, extremely
totally
competitive.
agree. I think that's to your point. I think the thing about a more government-oriented approach that I object to, or I should say I have skepticism about, is that it doesn't leave room for those kinds of innovations. There's so much innovation, the desire for innovation, both among patients and consumers and among entrepreneurs in the healthcare system. We want to leave room for that innovation to happen. One great example of this is the way that HIPAA, the healthcare privacy laws, anti-kickback statutes, and related legislation, regulations, make it almost impossible to do the kinds of things in healthcare IT that we take for granted with every other app we use on our smartphones. And so it's because these laws were designed for an age in which iPhones and smartphones didn't exist. So that's one example among many of where regulations are precluding the ability of entrepreneurs to find unique solutions to the system. So we want to leave room for that. And at the same time, we do want to make sure that people have the financial assistance they need to afford coverage, which again, isn't about so much regulation, it's about subsidies. We can have a much more efficient role for subsidies than we do. And the other piece of it is the monopoly piece. While we don't want to regulate innovators, I think it is important to be aware of monopoly power in healthcare in a way that I think in America we have not been up to this point. And part of the reason, by the way, is an ideological blind spot, which is to say that 3/4 of all American hospitals are nonprofit. And there are people on the left who believe that if you're a nonprofit, you must be good. And if you're a for-profit institution, you must be bad. And that's why, for example, prescription drug companies, which are entirely for-profit industry, that gets a lot of the heat from the left, whereas the hospitals, who are much more exploitative and much more a much larger component of healthcare spending, they get largely a free pass from the left, even though they're much more egregious actors. And so to your listeners who are more on the left, what I want to encourage them to do, whether they agree with me or disagree on the rest of the stuff, is to stop having a blind spot for organizations that, for accounting reasons and for tax purposes, call themselves nonprofit, but are just as, if not more, economically exploitative as any organization that pays taxes and considers itself for-profit.
Most of our listeners are employed by those hospitals, so
okay, sorry guys.
They may not make it, but no, Avik, it's so incredibly important that that folks like you do what you do in terms of being very effective, persuasive. You have an effective, persuasive way of bringing what you think as a solution to the table, which is driven not based on some type of ideology. You weren't born you weren't born in some libertarian type thing where you don't care about X, Y, and Z. You can certainly speak to a lot of the concerns that a lot of physicians certainly have in terms of providing access to folks and trying to expand access and whatnot. And too often, unfortunately, the debate becomes a moral one. So, it doesn't matter, Avik Roy is a conservative, he must hate poor people, and he just wants to reduce his tax rate, and it's really unfortunate that that's what the level of debate is in a lot of,
it's more accessible to people, right? The moral arguments are more accessible. So I get that. And again, that's why the empirical arguments are so important, because they're a place for common ground. If we can talk about the evidence, then whatever your moral perspective or vantage point is, we actually might find a solution that advances both of our value sets. At the time.
And more importantly is the idea, I think, that that there are very, very, very few folks in the healthcare debate that are certainly on a reasonable level aren't interested in trying to get access to as many folks as possible, and aren't interested in getting access to folks that don't have the economic means to. So the stuff you're doing is incredibly important. And I'm really glad that it seems, at least, like folks in this administration or whatever administration are going to hopefully be pulled by you in one direction or the other. We may not, all three of us may not agree on the actual final goalpost, but I don't think anyone can argue that for the three of us here, that moving towards something that you're proposing will certainly be better than the system that we may have now.
Let's hope.
Thanks for coming on, and I hope again you've written a tremendous amount in great detail, and have a lot of knowledge of the policy details of this, which are important in terms of making decisions. So I hope you'll agree to come on and join us later on as well.
Well, thanks for having me, and thanks for all the kind words. And it's been gratifying to. I mean, I started in this line of work with just as a guy who had opinions, a citizen who was concerned about the healthcare system, like both of you, and it's been a real privilege to have the opportunity to have an impact when I'm no different than anyone else in terms of having views and having a passion for it. So I feel very lucky and grateful that you're interested in what I have to say.
Great story.
Thank you very much, Avik.
All right,
Thanks.
guys, take care.
Bye bye.